was a necessary change. Some people would say it was mandated urgent change. Some would say it was intrusive change. Some would say it was a completely unnecessary change. Some would argue that it was very necessary. I think no matter what your perspective on the Berger Commission, I think the one adjective I think everybody can agree on, it was momentous change. And I think when you encounter momentous change like the Berger Commission brought about, it becomes incumbent upon us to take time to assess its impact. Was it necessary? Was it the appropriate course of action? Did it produce the anticipated results? If we forego such opportunities for review, such as we're doing today, not only do we not take advantage of our successes, we're almost assuredly doomed to repeat our mistakes. Now, I think more than ever, there is a need for a breakthrough in how we deliver care, access to care, quality of care. So learning from momentous changes such as the Berger Commission brought about is even more important than ever. With that in mind, I want to tell you how pleased I am to be here this morning with all of you and my esteemed colleagues to assess this impact. In the aftermath of Berger, Courtney mentioned really the number one question I get: did you know what you were getting into? And yes, I did. Not only was I interviewed, my interview was the first interview was the day that the Berger report was made public. But I'd also been through 3 mergers, consolidations before coming to Schenectady. And so I had a pretty good idea of actually what I was getting into. As the CEO of Ellis Hospital, which is arguably the most significantly Berger-impacted institution in New York State, it somehow seems appropriate for me to kick off these deliberations. And I want to do so by addressing 3 questions that I've heard debated most frequently. 1, did Berger get it right? 2, did we really need Berger? I mean, wouldn't all this have happened anyway without a Berger Commission intervention? And 3, what really was the impact of Berger at the grassroots level? Did it do any good? Did it accomplish what it set out to do? Now, each of us who are speaking this morning, and those of you who are in the audience, we come with different depths and breadths of experience and different perspectives. So the opinions may be different, but I think it's going to be really interesting to hear people's perspectives on these 3 questions. So let me start with the first one. Did Berger get it right? Were the recommendations the correct ones for health care in our state and in our region? And from my perspective, the answer is unequivocally yes. But I don't share this opinion from my perspective as the CEO of Ellis Hospital. I have spent, as mentioned, 35 years in healthcare, 16 years of which were in the metropolitan New York area, 5 were in western New York, and the last 8 have been here in the capital region. So when I reviewed the Berger report, I knew the institutions that were mentioned in it very, very well. I knew their histories, I knew their tribulations, and I also understand the inherent logic of the Berger report. The New York City hospitals that were named in the report had all struggled for decades. And when I worked in Buffalo, it was an accepted fact that Western New York had too many beds and too many hospitals. And in the capital region, 3 hospitals always seemed like a large number for Schenectady. I remember when I first got to the Schenectady community, I was stopped at a traffic intersection en route from Bellevue, a meeting at Bellevue to a meeting at St. Clair's. And I realized that 5 minutes behind me lay Bellevue Hospital. And if I made a left at this intersection, in 4 minutes I was going to be at St. Clair's. But if I made a right at that intersection, in 4 minutes I was going to be at Ellis. Schenectady is just too small of a city to be able to afford that kind of proximity. So yes, I think Berger got it right. Not only do I think did Berger get the institutions right, I think that the Commission also got the intent right. Their intent was not just to consolidate hospitals, but to leave those that remained more financially stable and operationally stronger. And it certainly accomplished that in Schenectady. But there'll be more on that later. Now, I don't want to be too boring, so let's interject some potential controversy, really not all that controversial, but there was one noticeable gap in the report, at least to some of us. And it is a potentially controversial subject given the company in the room. And that's why did the Berger Commission land so solidly on Schenectady, but seemingly bypass Troy region and its 3 hospitals. And when I say 3 hospitals, I am including Albany Meadow Memorial Hospitals Association with Samaritan. Some argue it was because the finances didn't support such a conclusion. Others argue it's because state politics, specifically Senate politics, didn't support such a conclusion. But I'd say, given how quickly after the Schenectady consolidation, the Troy area hospitals and St. Peter's agreed to merge, that this newest merger does kind of feel like a Berger echo. And so the question, why didn't the Berger Commission discuss consolidation within Troy in its report? You know what? With the passage of time and recent events, this is really a mood issue. So I don't want to dwell on it. Move on to the second question. Wouldn't all of this have happened anyway without the binding Berger recommendations? I'm going to start with my experience in Western New York. When I consider Western New York, I'd say it is highly unlikely that the Buffalo community would have taken the steps it recently has were it not forced to do so by Berger. I doubt Erie Medical Center would have agreed to assimilation with Coletta, nor would the St. Joseph's Chitawaka community or the Sisters Hospital communities have agreed to downsizing and reconfiguring their respective institutions. In point of fact, right after the Berger Commission was announced and came out, we heard of lawsuits from the city hospitals that were slated for closure. The Catholic Health System filed a lawsuit, and I think Erie County Medical Center filed a certificate of need for a major building program. So, even as this commission's report was about to become law, people were already beginning to kind of dish the recommendations. When it comes to Schenectady, given that I've been up to my eyeballs in these issues for the last 2 years, I can actually be even more definitive. Were it not for Berger, the 3 hospitals in Schenectady would never have consolidated as quickly or as effectively as they have. And it is very probable, in my opinion at least, that there may have never have been any real consolidation at all. I think we in this room have to appreciate that the seeds of distrust ran deep within the Schenectady community between the competing hospitals. And although there had been discussions of affiliation for years, nothing ever came of it. Ownership of the respective hospitals was so strong that no one wanted to really give up or give in. Principles of consolidation that are routinely accepted in for-profit mergers were completely dismissed or ignored in these discussions. Much of the interest in consolidation, frankly, appeared to be more intellectual. There was no apparent passion or emotional commitment to combining the healthcare facilities. So I conclude, were it not for the Berger Commission, there would still be 3 hospitals operating in Schenectady today. An equally interesting inquiry is whether mergers like Seton, Northeast, and St. Peter's would have come together so quickly if Berger hadn't forced consolidations like the one in Schenectady. Of course, that's a question better answered by Jim, and he's thanking me as I speak for teeing up all these questions for him. But I do want to throw my own 2 cents into this. It's not uncommon for discussions of affiliations and mergers to go on for years with little definitive progress, only to be pushed towards execution by seemingly serendipitous events. Now, I wouldn't exactly call Berger accidental, but the Berger-mandated consolidations may have caused a number of ongoing discussions throughout New York State to reach a tipping point, which, in combination with the current economic trends, made some affiliations more palatable to all the parties involved. I'm not suggesting that Berger initiated a merger mania, but momentous change does create tipping points, and tipping points have a way of cascading. I suspect we will be seeing the echoes of Berger for many years to come in our communities, and that is a very important impact of the Berger Commission on acute care in our region. Finally, question 3. What really was the impact of Berger at the grassroots level? And here I'm going to be talking about Schenectady because I consider Schenectady the ground zero level for Berger consolidation impact. When I thought about the answer to this question, I recall the meeting I attended at the Department of Health with Bob Perry, the president of St. Clair's, and Van Sale, the president of Bellevue Hospital. And they were discussing the impact, the mandates of Berger, the impact and the consequences of that, and their concerns. And when it came time for me to comment, I shared with them that my greatest nightmare was waking up and finding their two institutions closed and Ellis left alone to take care of the community with insufficient resources to do the job. And yet within a matter of months, that's virtually what happened. The perfect storm. Hospitals closing, patients moving, insufficient time or resources to reconfigure the physical facilities, and challenging cash flows from what effectively were startup operations on the Bellevue and McCollum campuses. So as I go through the slides and the impact on Schenectady and Ellis specifically, I'm going to ask you to keep this perfect storm analogy in mind, because I think you need to have it in mind in order to fully understand what the impact was on Ellis Hospital. Now, I'm going to ask you to consider a number of things. First of all, I'm going to ask you to consider the timetable of change that we were working with. And this is sort of an outline of it. November, the report gets released. January, it becomes law. March 31st, we in St. Clair's submit a memorandum of understanding and compliance with the Berger requirements. And, of course, in July 13th, an update with our plan for consolidation. And it's around this time that the train kind of veered to the right and came off the tracks, because in July, Bellevue announced it was surrendering its license and merging with us, actually consolidating operations with us. November 1st, we actually assumed responsibilities. That's a little over 90 days, gang. There are house closings that don't happen in 90 days. We did a hospital merger in 90 days. And we hadn't even gotten to November 1st when St. Clair's was saying to us, you know, our model is not working. We need to do something similar and consolidate operations and surrender our license. And so we started into discussions with the Department of Health, and in January 18th, we reached an agreement. Actually, it was more the Department of Health announced the agreement and the allocation of funds. And that left us a little bit over 4.5 months, because on June 16th, we basically assumed responsibilities for St. Clair's. I look at this calendar. It's a year by calendar. 2 consolidations, one that we were allowed 3.5 months for, the other that we did in 4.5 months. To go from 3 hospitals to 1 in a community in 1 year, that is just incredibly quick. And one of the lessons learned is once things are announced in the community will vote with its feet. I remember sitting in a room with the folks from St. Clair's and our consultant in the spring of 2007, talking about the movement of services and how we reconfigure it within the Schenectady region. And I remember this consultant at the end of the room saying, well, you know, here's the time frame. We're thinking that this is going to take about 2 years to do. And I remember looking down the table and said, 2 years? I just don't think we're going to get 2 years to do this. I think we're only going to get at most a year. Well, what we got wasn't a year, it wasn't 6 months, it was barely 3 months. People voted with their feet and they moved, and that's an important lesson to learn. Second, please consider what we had to do as Ellis and the staff of these other hospitals in bringing this about. Literally the thousands of details to bring about these consolidations. And forget the slides, I didn't really mean to get all those. I brought you a sample. Here's a sample of our worksheet. Now, things we had to do, this is an administrative and corporate, and we had to do things like, notify the state radiation board of ownership changes. We had to change scheduling. We had to make sure Joint Commission knew of ownership. We had a couple things on here. And everything on this list, by the way, had other tasks associated with it that cascaded down. And so this was a profound list of things that kind of kept on going on and on and on and on. I assure only, this is 287 items, folks, and this was the easy one. This was Bellevue. I can't begin to tell you how enormous this task was. It was a Herculean effort. And frankly, it was a huge burden to place on the back of the staffs that were already running a busy and large hospital. So there's a second lesson that I learned from this process, and that's you have to start your engines early. There is no way we would have gotten through the Bellevue transition successfully were it not for something that happened in late May, early June. I was actually having a casual conversation with Ann Sale, And she mentioned to me that in light of the Berger Commission's findings, here's an impact of Berger, their accountants were likely to issue a going concern notice in their audited statements. Kind of makes sense that Berger slated them for closure, right? Which was cascading down and trickling down to their malpractice insurance carrier, who said, you know, if you're going to get a going concern, we're not going to insure you. And she said, that's going to likely impact, you know, come November 1st. And I remember going home that night, going to sleep and waking up the next morning and saying, my God, she's going to have to close. That's what she was telling me. She's going to have to close. And so the next morning I called the senior staff in and I said, I want you to start today. This is like, again, late May, early June. I want you to start today developing an emergency plan for the assimilation of all responsibilities of Bellevue Hospital. And they looked at me and said, what? I said, we're going to have to start doing this. I truly believe that's the only way we got through the Bellevue transition, because we got really zero notice. And Neil Gold had a press conference. Now it's the first time I heard that they were actually going to surrender their license and merge with us. We had not kind of had that internal advance notice, we wouldn't have gotten through this thing. So if you're ever involved in something like this, start your engines early. The third thing is, consider what Ellis assumed. We took on responsibility for 1,133 employees, $118 million of operating expense, and you can see it, 10,000 plus patients, 43 additional days of care, 39,000 ER visits. And by the way, you know, when you say, you know, we took on responsibility for 1,133 employees, this wasn't a matter that just came in and changed their name tags. We had to basically hire all of them, which meant employment papers, physicals, checking licenses, changing benefits, summing them up for benefits. And when we assumed responsibility for the employees, the other thing we did is we basically took them on at the highest level we could. We paid them wages that were the higher of what they were already earning or what Ellis paid. We waived all the waiting periods for benefits. They started day one with benefits with us. If they were participating in the pension plan at St. Clair's, we let them participate in our pension plan or program day one. I used to kid with the staff, you're getting into the pension plan before I am, gang. We gave them full credit for all their years of service. If you were a 40-year employee at Bellevue or a 30-year employee at St. Clair's, we brought you over and gave you credit for the years of service. Now, Neisman gave us a little bit of a hard time about that, but we eventually, you know, worked that out. And I think that was a really critical factor, by the way. I mean, that's thousands and thousands of details on a tremendous assumption of responsibility, but I think it was also a critical part of making this transition go well. The volume of the responsibility in assuming this was tremendous. And in this stuff, you really, really had to sweat the details. So, let's talk about the results. First couple of lines are simply what we ended up. 455 total beds, 17,000 plus admissions, 2,800 babies delivered a year, 78,000 emergency room visits. That's the largest emergency room service in the capital region, by the way. 685 cardiac and thoracic surgeries. What other results? The next two things are newspaper quotes, and it's sort of like the results in the eye of the beholder. You know, we get through the Bellevue transition, and Times Union on November 2nd said the Bellevue takeover was seamless. And we went through St. Clair's, and the Times Union reported the hospital merger nearly painless. I mean, to go through what we just talked about and have people, I mean, we had our angst, we had our letters to the editor, we had people, you know, get angry. But to have people from the outside looking at this thing saying, it looks pretty seamless and pretty painless to me was really extraordinary. In fact, I had somebody call me a couple months ago and said, so how are things down there in Schenectady? When are you going to get started with that consolidation? I said, it's kind of all over already. He said, over? Where was I? Other result, $7 million operating loss turned into a $7 million operating gain. Now, if you go looking for this in financial statements, you're not going to find these numbers quite this way. I had access to the internal financial statements from St. Clair's and Bellevue and obviously Ellis. And what I did is I took the combined operations in 2007 and I took out any one-time Berger-related expenses or revenue. And then I did the same thing for 2008 and I compared the two. What were we like before Berger operationally and what were we like after Berger operationally? And truly, we went from a $7 million operating loss, 3 institutions operating independently, to a $7 million gain under one license in 2008. $14 million turnaround in 10 months. Now, admittedly, this does not include, this is Ellis for a year, Bellevue for a year, and St. Clair's for 7 months. So it does include the operating loss that St. Clair's might have incurred in the early part of 2008. But I can tell you, last quarter of 2008, we were clipping along at the rate of a $7 million gain. We're continuing to do that or better in 2009. So really an extraordinary financial turnaround. And in the midst of all this, we got awards for clinical quality and safety. Top 5% awards from in 2009 from Health Grades. They look at 5,000 hospitals. Basically, we're the only hospital in New York State to have been selected by them for those two awards simultaneously. And we're one of 76 hospitals out of the 5,000 they look at in the United States to do that. So, I think when you look at the results that get produced in the time frames that I've described, with all the details that have to be managed, and to do so really in a relatively seamless fashion, I really think those results are incredible. And we're very proud. We really are very proud of what we did. There are a couple of things to let you know about, and it wasn't all rosy. Here's the biggest challenge. Remember what I said about people voting with their feet before, you can get your act together? Here's an example of that happening. In April and May, people saw that St. Clair's was going to go through this transition, and all the patients shifted over to Ellis, both inpatients and ER. What happens when everything shifts and you can't bring your capacity online? Your beds get filled. You've got lots of patients in your emergency room. 78% of our admissions come through our ER. So what happens? People start to backlog in the emergency room. And the wait times went up to, what is that, 5.5 hours in our average in our ER. It was horrendous. By the fall, we had gotten it back down, and while we're not continuing to decline at that rate through 2009, we are continuing to improve our throughput in the ER. How did we do this? We doubled the size of the emergency room. We went from 22 treatment areas to 39 treatment areas by just grabbing space next to it, renovating it. We didn't ask permission. We asked for forgiveness afterwards. We just did it, and we were able. And we brought about 50 to 60 additional medical surgical beds online over the summer, so that we had places for them, and we basically got this under control. Biggest opportunity: staffing. In the midst of Berger, the VP for nursing at Ellis was kind of walking around saying, this is kind of like really a nice thing. I've got all this riches. I'm the luckiest VP for nursing around. So all of a sudden I've got a lot of nurses in the pool. And in fact, we have, I think the number is actually 850 nurses. There were about 300 nurses that came to us by way of Bellevue and St. Clair's as transitions. Tremendous opportunity. And you know what? Many of them have stayed with us. Our current rate of turnover amongst our nursing staff, that's the first 3 months projected for the rest of the year, annualized, is 70%. That's pretty low. And our vacancy rate in nursing right now is 3%. Our overall vacancy rate, 3.9%. Again, I think that, in a way, goes back to the way the employees were treated during the transition. So, let's talk about what went right. What went right in this whole process? I think what Berger did by narrowing the alternatives, it forced the consolidation and it shortened the time frames. People were not allowed to get out into the open and start discussing what-if scenarios ad infinitum. And I have to talk about two personalities that I think were key to the success of this in Schenectady. One is Jim Klein of the Department of Health, and the other is Joe Gersick, who was chairman of the board of Ellis Hospital. These two gentlemen really stuck to their guns. They really stuck. They limited the debate. They kept it focused. They didn't let people get outside. Had there been any equivocation on the part of either one of them, had there been any appeasement on the part of either one of them to special interest groups, we never would have come through this the way we did. It was because of the personalities and the drive of those two individuals that I think I relate much of the success of us being able to get through this as quickly as we did. Because again, limit the alternatives, narrow the debate, get on with it. Second thing that went right, Berger provided money through HEAL 4 that served as both an incentive and a means to making and implementing changes. And I said before, left to their own devices, hospitals would not have done this normally. But when you're showing up at the door with, $34 million to help a pension issue or $22 million to solve outstanding debt, that provides a lot of incentive for people to say, well, maybe I'll rethink my position. And the other thing it did is it brought money to the table that allowed current operating liabilities to be taken out of play. When we took responsibility for these two institutions, we basically took them without any encumbrances. And that was huge. Without that money and that commitment, we, Ellis, would never have had the means to make this happen. So it was sort of interesting. The HEAL money provided incentive as well as means. It was truly sort of an enabling event of the consolidation. Third, this was also a highly effective and efficient process. If I took this entire room out on a study and we tried to come up with the most effective mechanism for consolidating hospitals, we would not, I believe, have come up with a mechanism that was as effective and efficient as the Department of Health utilized. It was really, really kind of extraordinary. In combination with the HEAL program and the Dormitory Authority, facilities effectively surrendered their licenses. We transferred the responsibilities to the Ellis license, and we transferred all the assets, not the liabilities, all the assets without encumbrance. No debt, no liabilities. Highly effective process. Why? Because we didn't have to go through a merger. We didn't go through new corporations. We didn't have attorneys involved. Those of you who are attorneys, I apologize, but we had very little legal documents we had to go through. We didn't have long transition periods. Just to mention that everything wasn't rosy, we also didn't have much cash flow. But this long transition period is kind of important because if you had a long transition period in a time of uncertainty, employees get spooked, and they would have voted with their feet. So it was important to keep the transition period short. On the other hand, people have to grieve. Every single employee at Bellevue and every single employee at St. Clair's lost their job. Every single one of them. Oh, they had income with us. They had new jobs, but they lost their jobs with the institutions that many of them have worked at for 30, 40 years. And you had to allow a grieving process. But you couldn't let it go on for so long that people wobbled in the grief. So the fact that we had a reasonably short transition period, a little hard on management to make this thing happen, but I think it lent itself. It made for a quick, effective consolidation, providing, of course, you had responsible leaders. It's one thing for the Department of Health to take these hospitals and throw them and say, here, catch. It's quite another for institutions to be able to catch them and run with that. And I think at Ellis we actually had great leadership. And I don't mean just me. I think we had great leadership at the board. I think we had great medical staff leadership. And we had a group of people working, in the management ranks who, were really, really responsible people. They were knowledgeable, they were collaborative, they were flexible, they were resilient, and they worked their tails off. And that's actually what made this happen. I don't see Jerry Bunn in the room, is she? Jerry's not here. I don't usually get an opportunity to say things, acknowledge things publicly, but if you want to also talk about responsible leaders, I need to acknowledge the work that Jerry Bunn, who's the regional director for DOH, and all of her field staff did with us. You couldn't have asked for better colleagues. You couldn't have asked for more collaborative effort. They were there with us each step of the way. They were there with us all night as we went through the transitions at midnight. They were just tremendous, and I think that was an invaluable part of us being successful. But make no mistake about this. This could have been a disaster. In many other communities, in many other situations, I think it actually might have been. What's one other thing that went right? Consolidation of the medical staffs. There was a lot of overlap between the medical staffs, but in reality, the medical staffs played the hospitals off against each other. Once this consolidation came about through Berger, they no longer can do that. And there was an abrupt cessation of the medical equipment's arms race. I'm not saying a de-escalation. I'm not saying a truce. I'm saying day one, it stopped cold. I remember going into a meeting with our orthopedic guys who were very supportive of the hospital. One of the older physicians looked at me and said, I guess we're not going to be able to bully you and push you around, are we? And one of his colleagues said, no, I don't think we're going to be able to do that anymore, Dave, there was an immediate acknowledgement that they just couldn't play what has been an old historical game in healthcare. But there are some really positive things that came out of the consolidation of the medical staffs. When we reached out to them to participate in decision-making, which we've done, capital determination, what we're going to spend our money on, what we're going to buy, facilities, what programs, it really was helpful to have a consolidated medical staff that looked at the entire community. It was infinitely easy for the medical staff leaders to relate to the facility. You know, they only had to relate to one administrative staff. They only had to relate to one group of departmental leaders. So you could develop and sustain one-to-one relationships. There was better integration of the leadership. And frankly, it was also more convenient for the physicians. You know, one call schedule, one IT system, one department for their respective services rather than having to be in multiple ones. So that all, I think, went pretty well. What went wrong? I think DOH underestimated the cost. And, I'm not just saying this. Dan Sisto from Haney's, almost from day one, was saying, you do not understand, or the Berger Commission does not understand the full cost of what they're mandating. And I was in Erie County, and when it was part of the discussions when OLV, Our Lady of Victory, and Mercy South Buffalo merged. And I really don't think the transaction costs were studied. And that was, back in 2000 and, actually 1999, 2000. I think it would have benefited us had we studied those, because the cost to close a hospital is high. The cost to reconfigure care is even higher. And the cash flows in this kind of a transaction can be huge and are critical to the startup of the new business. You must remember that when we took responsibility for Bellevue, when we took responsibility for St. Clair's, we were starting from scratch. It took us 30, 60, 90 days to get paid. Right? Now, HEAL and DOH helped us on the Bellevue side. We got a $6 million loan to get us through those 3 months. But by the time St. Clair's rolled around, there wasn't enough money to do that. And we had projected our accounts receivable will run up to $20 million, and that's exactly where they went. $20 million. Now, they've come down, cash flow has improved, but they're nestling in right now around $12 million. That's $12 million of operating capital we had to invest as a startup business on the St. Clair's campus. I don't think people appreciate that. Let me talk a little bit about the role of state funding, however. Here's the breakdown of how the funding rolled into Schenectady. $78 million. More money rolled into Schenectady than any other community in New York State. The second runner-up was Western New York, and I think they were in the high 60s. So $78 million, $28 million goes to Bellevue, 50 to St. Clair's. Notice, if you will, that 81% of the money went to hospitals that closed. That left us with $14.5 million over here, which maybe sounds like a lot of money, but of this $5.8 million from the Bellevue transaction, 4.4 of that went into a revenue stream, sort of a one-time help to get through the transition. What do we need help with? We didn't do OB. Ellis didn't do OB. And all of a sudden we took on this institution that had 1,700 deliveries a year. And guess what? We're self-insured for malpractice. So what do you think our actuaries did? They said, oh, Jim, you need to put a little more money into your self-insurance fund, like $10 million. But we'll give you a break. You can do it over 3 years. The Department of Health helped us by giving us, part of that. Plus, remember the transition, IT costs, every form in the place has to be changed legally. All signage has to be changed legally. The costs are really, those hidden costs are significant. $8.7 million for Ellis St. Clair's transaction. Again, sounds like a lot of money. We are in the midst right now of moving the Ellis Center. That's 82 beds of long-term care that we operate from the Knott Street campus to the McCollum campus, because it's the best place to provide that facility. The McCollum campus, the former St. Clair's campus, is a great campus. Wonderful facilities and good parking, and it really will serve the elderly population in nursing home well. And that also allows us, once we vacate those 82 beds, allows us to recover some beds from med-surg. Probably the most cost-effective way we can add medical surgical beds in this community. Right? But that move alone is $8 million. How do I fund the rest of reconfiguration? I remember Jim Klein and Neil Benjamin, kind of poking me, and I would talk about this. They said, look, Jim, what's the issue here? We're giving you a monopoly of care in Schenectady. And I said, that's great. You're giving me a monopoly, the equivalent of a plans that that make LP non-compliant records, and I live in an iPod world. I got to reconfigure care, and there wasn't sufficient resources to do it. There still aren't. Lesson to be drawn from this: having a monopoly does not generate capital. What was the most unexpected thing that happened to us in Berger? I think Bellevue surrendering its license really caught us by surprise. I believe it was the malpractice issue that ultimately forced that issue, the inability to get malpractice coverage. And when that happened, it left them with no options. Either it was bankruptcy or accept the Berger mandates. And when it happened, when Ann and Neil announced they were going to do this, it was almost surreal. You knew it was going to happen, you kind of expected it to happen, but you couldn't almost believe your ears, and that it actually was happening, and it happened very, very suddenly. And it was a watershed event for us, because Ellis just couldn't let Bellevue's OB service dissipate. They were 70% of the OB market in our area. We just couldn't let them close and leave the community. We had to reach out and keep it in the community. And we couldn't take their OB work and consolidate it at St. Clair's Hospital at the time for a couple of reasons. One, Merger Watch was just sitting back waiting for us to do something like this. And I think the Catholic issues of putting all OB in a Catholic hospital, all OB in a community in a Catholic hospital, were really going to trigger a lot of problems. Secondly, Bellevue did 1,700 deliveries, St. Clair's did 800. I couldn't fit 1,700 into the 800 facility, but I could do the reverse. To have moved everything to St. Clair's would have required a lot of renovation, and we had already, with St. Clair's, agreed that that wasn't long-term what we wanted to have OB. So basically, we were left without a choice. We had to take responsibility for the Bellevue campus. We had to keep it operational. I think what that did is it caused a rapid acceleration of St. Clair's descent into a financial death spiral. I don't think the Department of Health anticipated it. I don't think anybody really anticipated it. But I think that's exactly what happened. When Bellevue decided to close this, we were assuming we'd have a lot of time, a year or more, to do this transition with Bellevue. When they said, I'm closing, it tripped St. Clair's into that death spiral, unfortunately. And the speed with which events moved was really surprising. Before even Bellevue closed, and I mentioned this, St. Clair's agreed to surrender its license, and staff and patients started to move. Even though the date was June 16th that we assumed responsibility, I had hired all of their RNs by the 1st of June to keep them in the community. And on the 16th, we did assume responsibility for St. Clair's, 16th of June. And on the 20th of June, they were out of the inpatient business. That's how fast things moved. What's been the greatest benefit of Berger? Been stability, stronger hospital, greater consistency, retain employees, sure, all those things are nice. But in Schenectady, here's the greatest benefit. Enhancement of community health. Overnight, our working relationships with other organizations changed. Your mindset changed. Their mindset changes overnight. You find yourself one provider, in one community, with one population, and with one pool of resources to draw from. And so we're moving in the direction of creating a medical home for the uninsured, the underserved, where they can come to get their care on our campus. And I'm out there talking with organizations that provide social services and other health-related services in the community to say, how can we work together? And sometimes people say to me, you know what? You don't exactly talk like a hospital CEO. And I said, look, let me maybe kind of explain what's changed here. We can take care of people in our community preemptively. We can screen them, we can give them primary care, we can encourage people to see the dentist so that they can chew their food and absorb the nutrients. We can make sure kids get inoculated, we can make sure people get insured. And that's going to cost us something, but the care is going to be continuous and the care is going to be good quality. Or I can wait until they show up in my emergency room as train wrecks. And the care on that particular episode might be good, but since it's not contiguous, there's no consistency, overall quality won't be as great. And it's going to be very, very expensive. And you know what? No matter which alternative I select, primary care or the ER, I am paying the freight. I incur the cost. Because our commitment to this community as a sole provider is to continue to fulfill the mission that St. Clair has carried out so well, which is to be the safety net for all the people in that community. We are a major provider of primary care. Berger has actually generated the opportunity to plan and coordinate in a way that previously we could only dream about. It has actually given us a chance in that community to do the right thing. It is a very special gift. It's something we're learning to appreciate and we're learning to treasure. And I think we're doing everything we can to fulfill the opportunity that we can give. Thank you very much.
We had the statewide commission, and that was not me. I wasn't on the statewide commission, but we had these regional advisory councils. And when they first got set up, there were 3 of us. There was Dick Nathan from the Rockefeller Institute, myself, and Laura Leeds, and we were the regional advisory council for this region. And then we did an interim report, or Courtney did an interim report. She listened to us and wrote the report. And then we had 3 more members added to our regional advisory council final report that went to the commission. Commission deliberated and then made their final recommendations. And if I remember to do it, I can also address the question that Jim brought up about the issues of Troy and Albany versus Schenectady and so forth. But that was the setup, and it was interesting. I really had mixed emotions about being. I wanted to be on the regional advisory council. I wanted to be on the Berger Commission, and I wasn't 100% sure why. Because to Jim's question, did Berger get it right? The big question in my mind was, were we really targeting the right question? Because think of what the situation is for those of us running, well, we'll say hospitals in this case, but for Northeast Health, it's an entire system. What do you think my biggest cost is? It's not fixed cost, it's variable cost. That's 70% of my P&L at the end of the day. And what drives my variable costs? What really makes a difference at the end of the day? It's staff. And if nurses are in short supply and the cost of a nurse is going up faster than inflation, guess what healthcare costs are going to do no matter what you do about the fixed cost side? You can close and close and close, but you don't change the number of patients who have to be cared for. And the cost for them, yeah, it's nice, you'll reduce depreciation and you won't have to heat that wing and so forth, but at the end of the day, you haven't changed the number of patients who need to be taken care of, and it was the variable costs that really were a lot of the problem. And it was sort of like, it's been said about healthcare, sort of what got us, one of the reasons that got us into this situation where you needed a Berger was the old field of dreams, build it and they will come. If we build a hospital, don't worry, we'll fill it up. Or the docs go out and build one of their freestandings, don't worry, we'll fill up the freestanding. And the Berger Commission was kind of, to me in my mind, as I was thinking about whether I really wanted to be on this, was sort of the opposite of that field of dreams. It was, if you unbuild it, they will go away. The idea that, if you just didn't have a hospital, somehow these patients were still going to be there. Somebody was going to have to take care of them. So my concern about going on the Berger Commission was, were we really addressing the question that really needed to be addressed, which was that whole variable cost side and so forth and so on, and what inflation was doing, and from there. So I had that doubt, but at the same time, I also felt a certain responsibility, and I think Jim alluded to it a little bit, but I really see the Berger Commission as being caused by the failure of the healthcare industry to step up to what needed to be done. And let me explain that a little bit, and I'll tell a story that I've told before about this. I worked, as Courtney mentioned, I worked for the Union Pacific Corporation. I was Director of Acquisitions and Divestitures for them. And then I did what everybody did in the middle of their career. I went to medical school. And for the summer, between your first and second year of medical school, that's the only summer that you have off. The other summers, you're doing clerkships and things like that. So I had the summer off between my first and second year. And what you typically do down at Cornell Medical School down in the city is, you do research, work with the professors and things like that. Well, by that point, I was married and had my first child, so I wasn't going to be doing research. And Union Pacific said to me, look, we've got to look. We're looking for a major acquisition. We know the bulk of the work's going to be done in the summer. And I got invited back this summer to be, for those 3 months, in my old job as Director of Acquisitions for the Union Pacific Company, while we targeted particular, there were several industries we were looking at, and lo and behold, one of the industries they wanted to look at was the healthcare industry. And I won't go into why and all the details. I mean, that's a whole other case study that's interesting. So we looked at the healthcare industry, and typically we would look at an industry 3 to 6 months. We could, we're down in Manhattan, that's where their corporate headquarters where we call in all these experts and everything. And we're doing this for healthcare, and we literally spent 9 days looking at the healthcare industry and completely abandoned it. We said, and I'll tell you the story as to why this happened. We would sit there, I've told this story a lot, so I apologize, but we would sit there and we could call in these experts, and we would call people in, and healthcare guys would come in and these consultants, and if you let them talk for about half an hour, it made a lot of sense. You could see how, we could do this, we could put this together, but you let them run for an hour, and all of a sudden they started contradicting themselves. And you began to gradually, the lights come on pretty quickly for us, was the people in healthcare really didn't understand how healthcare worked. They didn't understand their drivers, and guess what? As we looked at it, there were no IT systems. Back then when we were doing this, there were no IT systems, so they couldn't understand it. But the real killer, and the reason we walked away so quickly from healthcare, and I think is so apropos now, you talk about what goes around comes around, was it was too fragmented to ever be a cost-effective industry. The pieces were all these little pieces. Let's take the Capital District. You got all these hospitals up here and all these individual pieces. And how are we ever going to create a cost-effective industry out of those kinds of pieces? And we walked away from it. And of course, what goes around comes around. I wind up in healthcare years later, and God was out to get me or something. But what happened between then and now has been very, very interesting to watch, because it was the lead up to, I think, what happened causing Berger. And there was a horse race going on in healthcare. And you could almost watch it in the papers over those years. And the horse race was which segment of healthcare was going to consolidate most rapidly. Who was going to be first, who was going to be second, and who was going to be third. And remember the pieces in this horse race, so the horses you're watching, I didn't realize, very apropos with the Derby tomorrow, were the payers, the insurance companies. Already the two biggest payers were very consolidated, Medicaid and Medicare, but the commercial guys were all consolidating. There were the docs, and of course, having been in a medical practice, a group medical practice for 10 years, I couldn't imagine a group that was less set up in terms of personalities to merge, and yet that's exactly what happened over the intervening time between the time we were looking at this and now. So there were the payers, there were the docs, there were the facilities, the providers, hospitals, nursing homes, and so forth, and then one could also argue that aren't the patients, the customers in here somewhere, were they going to consolidate, and so forth. And what happened during that time was the payers consolidated. I mean, let's face it, CDPHP in this region, with all due respect to all the commercial payers, CDPHP really has an effective monopoly. And I don't mean that in a bad way. I just mean they really dictate, for those of us who are in practice, that was the one you looked at if you really wanted to try to memorize one of the formularies and so forth. They really drive the bus. If you look at what the physicians did, look at this area. When I started in practice, there were lots of onesies and twosies around, but now we've got community care physicians, we've got prime care, we got capital care over in Schenectady. The docs were all consolidating. But the one group in this sort of horse race that wasn't consolidating were the facilities. You didn't hear about it. It just didn't happen. In fact, Northeast Health, when Albany Memorial came on board to Northeast Health, that consolidation, and that was 97, that's a little bit of a consolidation, but not very much. So the fact of the matter is, we were winding up with a continuation of one piece of the healthcare puzzle staying very, very fragmented. Now, in any industry that you ever look at, if you're the last guy to the consolidation party, you will get eaten alive financially. And in fact, what happened in New York State? You know what the average operating margin is in New York State for a hospital? I mean, assuming you're in the black, it's about 1 or 2%. It's less than the cost of capital, which by definition means eventually you go out of business. You simply can't replace your capital base. And what happened, and has happened in New York State because of all this is, if you look at the average age of plant of healthcare facilities in this country, you know where New York ranks? Second to last. We have the second oldest healthcare plant in the United States. Now, if you think of this as a business, if you're the oldest compared to your competitors, what do you wind up with? Obviously, lower cost efficiency. It can impact quality. It can impact a lot of things. So this whole issue of fragmentation isn't just sort of like, that's an interesting concept. it has tremendous implications for exactly where New York State has wound up in terms of its health care. And I would argue the fact that we didn't step up and do this consolidation ourselves is what gave rise to Berger. Eventually, the government had to step up and say, enough is enough, we've got to start consolidating this so we can start moving in the direction that Jim actually outlined the specifics of, and I think was very appropriate. Now, let me talk a little bit about consolidation, because I think Jim said it, kind of hinted out at some of the things that he talked about. Consolidation is often seen, and I was referring to it, as a means toward a better bottom line. But actually what consolidation does, it does many other things, and one of the biggest impacts that I think it does is it creates the opportunity for innovation. And I think that's been the problem in healthcare in New York State and in much of the country is when you look at healthcare reform, what we're really asking for is innovation, but not in bigger and better CAT scanners. What we're looking for is innovation in the way we actually render healthcare. In other words, and this is near and dear to Northeast Health heart, this whole idea of coordinated care across the whole spectrum. Now let's talk about, that's in Obama's plan, that's in every plan you ever hear about. How are we going to reduce costs and increase quality of care? But we're going to do better on this chronic care, caring for people across all the transitions of care. Well, how are you going to do that in a fragmented healthcare system? The answer is you aren't, and it won't happen. And as long as we remain fragmented, it's not just an issue of the bottom line. It is going from minus 7 million to plus 7 million. That's crucial. But we can't innovate along clinical lines as long as we're fragmented. We need the consolidation in order to achieve that. And the other part that it's very, very important for, and this actually I'll talk about a little bit more, is in terms of the business model for healthcare. If there's one topic I get asked, I was just down at Bassett, talking to Bassett Healthcare's board of directors, they wanted me to talk about this business perspective on healthcare, and where does healthcare fall, and is it a fish or fowl, and so forth. You can't come up with new business models very easily in this fragmented an industry. If John Bennett, a CEO of CDPHP, tomorrow, which actually I'll be there tomorrow, they're having their board retreat tomorrow, and I'm up there speaking to them about this specific topic. If they want to introduce a new reimbursement method, instead of just paying us to do more, remember that's the way our payment system works now. We're paid for clicks. The more we do, the more we get paid. So guess what happens in the healthcare system? It just does more. Well, if we're going to change that business model, so let's say John Bennett, a CEO of the largest health plan in the region, decides he's got a new model. He wants to do something. Think of what he's got ahead of him to try to change that business model in this region. He would have to put Jim Connolly, Jim Reedy, Jim Barba, Steve Boyle, Gino Pazaglini, and then if you want to throw in Saratoga and Glens Falls and everybody else, the number of people he'd have to put in a room, first off, we don't all get together anyway, because, everybody always thinks we're, cooking up something illegal, but it's very, very hard in a fragmented system to change the business model because you can't put enough of the pieces together to actually have an impact. And that's been stymieing John Bennett and CDPHP, and in fact, that's the discussion we're not going to be having as a result of this potential merger we're going to go through, is can we change that, actually change that business model. Now, there's another piece of this that I also want to mention. Jim was alluding to it, and I think it's important relative to Berger and what it achieves through all this consolidation, and that is the issue of cost efficiency. And let me go on a little bit of a jag here because this is a hot topic for me. The first job I ever had in the corporate world was manager of cost control for one of the divisions of the International Paper Company, and I'm fascinated that I'll say in New York State, but I think it's more than that, we always talk about, well, we want to lower the cost of healthcare. That's really what we're aiming for. Does anybody in this room know what the most cost-efficient hospital is in the capital region? First, if you're really smart, you'll say, for which diagnosis, Jim? So let's say for pneumonia. Obviously you're all interested in healthcare reform, and at the top of the list is to reduce the cost of healthcare, right? That's what we're trying to do. Does anybody have any idea, if this is such a hot topic that's really out there, what's the most cost-efficient hospital? Yeah. The answer is you have no idea. And guess who else doesn't have any idea? and I don't mean this obviously as criticism. John Bennett at CDPHP, he doesn't know which the most cost-effective is. I don't know which the most cost-efficient is. I certainly know the cost efficiencies at Albany Memorial and Samaritan Hospital, and I can talk about them in detail. I have no idea what the cost efficiency is at Ellis. I don't know what the cost efficiency is at Albany Med. Interestingly, I was a member of the State House Review and Planning Council. When someone wants to build a big new hospital or new equipment or something, it goes to the Department of Health, and then it comes to us at SHRPIT, and we look at it and we say yay or nay, and then it goes on to the commissioner, either gets approved or not. It's interesting for me, sitting there thinking that cost is so important, I never saw a cost efficiency number ever in the time that I sat on SHRPIT. I saw capital costs. I knew it was going to cost $200 million if we did this at this particular hospital in this community. But let me ask you, let's say there are 3 hospitals in the community, and we decide to do approve a $200 million expansion. Did I just improve the cost structure of healthcare in the community, or didn't I? Well, I don't know. I may have invested in the highest cost hospital in the entire community, but I have no idea. What do you think when I was back at International Paper and we would be expanding a plant in the weight papers division, what do you think we did? We looked for our most cost-efficient plant, and that's where we put our capital. So guess what we eventually had in the weight papers division? We had a very cost-efficient manufacturing operation. In healthcare, and I'm not criticizing anybody, I'm just pointing out facts here, we don't know that piece of information, so how can we possibly make investment decisions that eventually lead you to a cost-efficient healthcare system? We don't have that data. And for instance, let's look at Berger, and that's what I was trying to work back to. One of my frustrations sitting on Berger was we were trying to make a decision differently than I was used to if I were making the same decision in the for-profit manufacturing or corporate sector. We weren't able to look at those kind of numbers because we simply don't have them. It's not a question of the Department of Health doing something wrong or somebody else. It's we didn't have those. And I think at the end of the day, that fragmentation was exactly the cause of that. We don't have enough under an umbrella to actually look at where the most efficient place is to put a particular capital expenditure. Hence, we wind up in exactly the situation we're in. So, let me go to the next step then. And to Jim's point, why didn't the healthcare industry step up to this? Why did we need Berger? That could be a justification for it or just an observation. I mean, certainly one of the first things that people say, turf battles. Jim wants to defend his turf. The Jim that isn't here wants to defend his turf. I want to defend ours. And that's what it seemed. It's a big turf battle. Alternative way of looking at turf battles is to say, I have a mission that I have specifically stated and I have to keep from a fiduciary standpoint and a commitment to the community standpoint to my board, and I believe in that mission. Jim has a mission, he believes in that. If Jim Barber were here, he believes in that. So there's sort of 2 ways to look at that turf battle, but that's part of it. But let me tell you the 2 that I really think were sort of major players as to why we wound up in this quote-unquote overcapacity situation. And they may seem a little esoteric to you, but this is based on literally what I do every day in my role as CEO of Northeast Health and the kind of things I worry about. I ask myself, why did we wind up, our system or any system, with this excess capacity? And to be honest, I mean, yeah, the turf and all those kinds of things are there, but we still could have had the conversations, but there were 2 big problems. One is a legal problem. I'll tell you, you will very rarely ever see myself and Jim Barba, or myself and Steve Boyle, or Steve and Jim Barba sitting down at lunch in the main dining room at the Fort Orange Club. Because immediately people are going to say, I mean, and what are we, we're all just going through a big class action suit because supposedly we were trying to depress nurses' wages, which I find, I mean, if anything, we're doing everything we can to push them up because we know what our shortest supply factor is. But in any case, legally, we can't sit down and optimize capacity because there's a law about what's called market splitting. If in Troy, Jim brought up Troy, if I walk down the street and sit down with Gino Pazzaglini and I say to Gino, look, why don't you take cardiology? I'll take surgery. We'll focus them that way. We'll be more efficient. Get rid of this medical arms race stuff and so forth. We go to jail. In fact, I'm not an expert. I don't even think it's a fine. I think it's a felony for us to market split. And that's what market splitting is. So we legally can't have that discussion. And if you think that's just an esoteric point, let me tell you, I think about it all the time when I'm sitting down with Steve or Jim, anybody, about exactly what we're talking about. And if we start to drift into a subject about how we might be able to make this a more optimized kind of system, unless we have a memorandum of understanding where we have publicly declared that we're in merger discussions, that discussion can't happen. And let me tell you the other one. Now this one I really believe in. So I'm going to say it, and you may not buy where I'm going on this. But 5 years from now, you'll look back, and then maybe you'll believe me. There is an inherent difference in healthcare that drives it to an overcapacity situation, unlike any of the industries that I've been in, whether it's transportation, paper, natural resources, and so forth. And let me just show you what I mean. Could you just... All right. I'd like to say this is all self-explanatory, but it's not. I asked for one of our hospitals, I asked our CFO once, I wanted him to run for me, for every day of the year, the number of clicks that our plant did. Meaning, this is 365 days a year, and this is how many things, this particular, I think it was Albany Memorial Hospital, this is how many things they did that day. Could have been an admission, could have been an outpatient procedure, could have been a blood draw, could have been an x-ray, could have been whatever, all right? So here's my plant that I'm running, and this is the swing in volume every day of this plant that I have to run, and I want to optimize the capacity. I want to avoid a Berger Commission, and I'm just going to run this very, very efficiently. Well, let's say this is one of the paper machines at International Paper Company. First off, just having been in business and seen this, I gulped as soon as I saw this. You don't like to be in businesses that have this kind of swing. You try to optimize a plant. But let's say this were paper industry. Here's a day when demand is very, very low, and what would I do? I'd be cranking my machine right along here, and I'd be putting it into inventory, right? And then I'm going to hit this day where demand's really high. What am I going to do? I'm going to keep my capacity right where it's always been. That's easy. And I'm just going to take it out of inventory, right? Or let's say this were a restaurant, and you called up and wanted a reservation at 7 o'clock, and I've got really high demand. What would I say to you? Can't seat you at 7, but I can seat you at 8:30. In every other industry I know of, what we do, and what I did in my previous life was, we load leveled this. We built our plant right here at the most optimal, so that we knew we had the most optimal fixed cost structure we could possibly have, and then we dealt with this around it. Now here's the problem in healthcare. What if I did that? Well, it looks about half the days of the year I would put a closed sign outside Albany Memorial Hospital and say, we would love to see you today, but we're closed. And if you came on this day with acute chest pain radiating to your left arm, I'd say, terrific, step right into our emergency room. If you showed up with that right lower quadrant pain, the beginning of that gallbladder on this day, I'd say, well, maybe somebody down the street, but not us. The fact of the matter is, we're in a business that we can't optimize that way. In fact, we were doing, I tell this story, we wanted to do a master facilities plan for one of our hospitals, and we brought in TRO, the Ritchie organization, big engineering organization that designed hospitals. We said, if we had unlimited capital, how would we design that hospital perfectly for the community? And they had only one question that we had to answer, and then their computers and stuff ran the rest of it. Anybody want to guess what the one question we had to tell them is? What percentage of the days of the year do you want to be on diversion? Meaning, what percentage of the days of the year was I willing to hang a closed sign outside Albany Memorial? Well, guess what that number is? I mean, when you tell me you're the community, we can make that number. Jim can close down half his capacity, and you bet he'll be running full. I can make Albany Memorial run full tomorrow. I'll just shut down the capacity to right here, and I'm going to be full. But I'm going to be telling you 50% of the days you got to go find another hospital, no matter what. So we don't get away with that in healthcare. 10% of the days maybe on diversion, something like that. In other words, what I've got to do is I've got to take this line and put it way up here, which by definition means I'm over capacity. Now I do get carried away on this, and I apologize, but it just sitting at Berger, I'd already been through all this in several other industries, and this wasn't an industry that lent itself to this idea of optimal capacity. The optimal capacity you can't do in this industry the way other people would do. You can turn it off. I can go longer on that one, but I won't. I'll leave it there. The other thing, so the question to me was, and again, being on the rack and so forth, was, so we did this. We came out with the recommendations for Schenectady, and the question is, what's the solution going forward? Should we be thinking in terms of a Berger 2? I mean, do we get the low-hanging fruit, and do we go through this process again, and then keep iterating it until we get into an even tighter situation, supposedly more optimal? My answer would be, well, the problem with Berger was we were often trying to cure something with a sledgehammer where we needed a scalpel. And Jim actually mentioned it very quickly in one of the points that he made, and that was the issue in healthcare very often isn't facility, it's service line. That is, the issue isn't do I need to close this facility? Is it that I need to have all my cardiology over here and have exactly the right amount of equipment needed for that rather than duplicated over here as well, but then maybe put orthopedics or something else over here and wind up with, number one, a more efficient facility, because what am I going to do on that chart? I just very subtly have blood level it, right? Number two, what did I just do for the physicians? They are going to be a whole lot more efficient. Instead of covering 4 or 5 hospitals, I put their service line, let's say, at 1 hospital or maybe 2. They're going to be a whole lot more efficient, right? So as we try to handle one of the big problems in this area, which is to attract new physicians in, guess whose job just got a whole lot easier? The docs attracting for their succession planning. And number 3, what would I have just done in terms of the patient experience? Obviously, you get one of those focused kinds of operations. It makes for a much better patient experience as well. So, in looking forward and thinking about this, the option to a Berger 2 and so forth is maybe the industry actually steps up to this consolidation issue. Maybe we decide we're going to get rid of this fragmentation ourselves because rather than having to close facilities, what we really need to do is take the existing facilities and optimize the capital base that we already have. But what did I just say? Well, Jim, you can't do that because legally, if you try to do that, you just told me you're going to jail. Well, I can if I do a merger. So if Steve Boyle, and Jim Reed, and Gino Pazziglini sit down and bring 3 healthcare systems together, you put yourself in our place, whoever winds up running this, and all of a sudden this gets to be a very, very interesting discussion because we can do things that Berger couldn't do. As we sat in the room back there and we're working on this, we don't have to use the sledgehammer. We can start using the scalpel. To Jim's point about Troy, so how do you solve Troy? Troy has always been in the worst possible situation. If it needed 1 hospital, that would have been easy. You close one of them. If it needed 2 hospitals, you got 2 hospitals. The problem for Troy forever has been it's needed 1.5 hospitals. So the issue is, what do? Well, we want cardiac cath over there. We don't build 1 cardiac cath. We build 2, and we share it between the 2 hospitals. Not an efficient way to approach capital and so forth. But if we put those 2 hospitals under 1 umbrella and start rationalizing services between them, we can obviously improve the operating efficiencies related to it, and obviously make for, I think, a much better patient experience. And we solve the problem not by suddenly closing one and then suddenly having to do all this construction on one of the other campuses. We optimize the asset base that we already have. We, in essence, do what any other industry would have done in this situation. Mergers occur, we get consolidation, we get optimization of the capital base, and we improve the experience of the customer. We get economies of scale. A couple of other things that we're going to do as we work on this merger. And the merger that we're talking about, and I went longer than I meant to, so I won't go into the merger, but I'll just say what this merger is meant to do is really healthcare reform. This is not designed to close facilities, layoffs, those kinds of things, because when you look at the numbers going in, it just doesn't look like it. That's where the value is. The value of this is in healthcare reform, and I'll use a couple of the interesting examples that I've seen just recently. One of the things that the Berger Commission recommended and we talked about over and over again, and I heard the commissioners on the statewide commission talk about, was what we need to do is move patients out of institutions and into the home care setting. It's less expensive. It's a better experience for the patient. Let's not have them sitting in nursing homes if they can possibly be taken care of by home care in their home. Let's get them out of the hospital faster, get them into that home care setting, and have the physical therapist come to their home after that hip replacement or whatever the case might be. Well, that's nice, but if your whatever facility had the person first, guess what you want to do? You want to hang on to them. If you're home care, you want to get that patient. So we start getting these turf battles, right? If we can put all those under a common umbrella, the organization can then look at the community and say, holy cow, we can do this much more cost effectively in the home care setting. And there's a very strong advantage for them to be doing that. And what happened with the latest state budget that came out? I obviously have a soapbox I can do on the budget, but I understand our budget deficits. But instead of using that scalpel and saying, like to the Berger Commission, well, we want to move people to that home care setting, what did we do in the healthcare cuts? We just went right across the board and took it all out. Let me tell you, in healthcare, the most vulnerable industry, the part of healthcare that this community, I am predicting very comfortably, we will be losing first, will be the home care side. And that's exactly, if you read the Berger report, and if you sat in those meetings, that's exactly the opposite of what Berger wanted to accomplish. We wanted to move patients in that direction, and right now, that is the most vulnerable part of the healthcare continuum in this region, and it has directly to do with reimbursement and so forth. So I just want to be out there having said that. But you put it inside a larger merged entity, and we can start making some changes and moving things, and I think eliminate that turf issue that comes along with that and so forth. The one other example I want to use that on the merger issue, and because I think it applies to a lot of this, is we always have a joke going within Northeast Health. Michelle Mazzocco runs our home care division, and one of the real quality drives in home care today is to reduce readmissions to the hospital. Somebody congestive heart failure, gets discharged, home care is taking care of them. The real goal that they're being measured on is what percentage wind up back in the hospital. Well, we'll be in a management meeting. Norm Dasher, who's my CEO for our hospital side, Michelle will report out, we've reduced, we've got this new program, we're going to be reducing readmissions, and Norm's always turns and looks at her and says, Michelle, God, I hope you are so unsuccessful at that we're just laughing at you in a year. And we chuckle just like this. Our management meeting, there'll be little chuckles that go around the table, but there is an inherent mismatch in our fragmented healthcare system, because as much as we laugh about that, that's exactly the way the reimbursement system works. It behooves Norm for Michelle to be unsuccessful in doing what is clinically right from a community standpoint. And even though no one comes in the morning and says, gee, let's see if I can get this person back in the hospital, nonetheless, the business model in the system isn't set up to accomplish what it is we really want to accomplish in healthcare reform and so forth for the community. Now, picture that in a merged entity. Now, all of a sudden, it gets much more interesting, because since it's, from a financial standpoint, the total bottom line, and in terms of being judged by the community, it's the overall health of the community, this business of reducing readmissions, what we found, the really smart thing you did was, you took the nurses on the inpatient side and taught them what was going to be happening on the outpatient side, and you taught the outpatient nurses what had happened to that congestive heart failure patient inpatient, and then you can start working the transitions. It becomes much, much more effective, fewer errors made, and so forth. Well, if we're all part of one system, guess what we can do? We can do that very effectively. Separate systems, we can't. So the point I'll wrap up by saying is, I think the obvious one here, what Berger really did was, it said, look, we're going to get this consolidation piece to some degree. We're going to do these, lots of political reasons we can't do this one or that one and so forth. But to Jim's point, we're basically going to set to the healthcare industry a choice. Either we can have what happened in Schenectady, and what's happening in Kingston, is that forced consolidation, or healthcare, our industry in this area, can decide to go down the other path, do the consolidation ourselves, and basically achieve what we had to use a sledgehammer with on Berger, we can now start using the scalpel in terms of a single merged entity, a consolidated system of working on individual service lines and individual issues. And I would submit at the end of the day, that's the way New York State wants to have healthcare reform, not have to resort back to the sledgehammer approach. So I think that's sort of the dividing line, and you're going to see people going down one or the other of them. And I think if we as a system, we as a healthcare and industry in New York State step up and are also allowed to do these kinds of consolidations, you won't see the need for the Berger 2s and Berger 3s, because we're going to be achieving exactly the kind of healthcare reform that we need. And with that, Courtney, thank you very much.
This new model of care, and Jim talked about managing the continuity of care. The similarity here is I was talking about a medical home. Same concept. How do you manage the continuum of care in the community in an entirely different way? And yeah, Berger offers us the opportunity to embrace innovation. If we don't, we're really in a world of hurt. I think the thing that I most need to do in Schenectady to improve the healthcare of the community, housing, transportation, nutrition, wrapped around that is healthcare. That's what we need to do. And this home care thing, I think one of the greatest tools I've got at my disposal is being chairman of the visiting nurse service. That's a wonderful opportunity. Cardiology in this community is starting to decline. Cardiac surgery at Albany Med, at our place, down 20-25%. The cardiologists are crying because they don't have enough. They're concerned because they don't have their care. We're doing too good a job on cardiology, and people are upset, right? But we're doing the right thing, but it's so tied to revenue, it scares people. And lastly, Jim talked about this economic model of supply and demand, which is really interesting. I think there's another disconnect. You talk to most people about, just make healthcare more competitive, and why doesn't it just work like other industries? We probably both do that a lot of times. Describe in another industry what the economics are like. You have a supplier, goods and services. You have a purchaser, right? Customer, consumer, purchaser. In healthcare, the customer is the patient, the consumer is the doctor, and the purchaser is the third-party payer. And those people don't get along together, usually. So the problem is the economics in healthcare are all askew and don't at all match what we typically see in our own economics. So not only is the supply and demand model off, but so is the economics. And one of the things that I hope can happen in Schenectady is actually we can get down to one system, one provider. Maybe you can make those economics align up a little bit better so that you can have innovative change.
Thank you for the additional comments. Very good points. We have some time for questions, and I would ask people that when you ask your question that you also state your name first. I'm going to take this opportunity, though, to ask the first question, then I'll call on members from the audience. Since Northeast Health, and this is really a question for both of you, Northeast Health is unique in the upstate region in that it has that continuum of care. It has the acute care, it has the long-term care. I wonder, now that you've had this memorandum of agreement put in place to better consolidate the services for Northeast Health, why that memorandum isn't even bigger. Schenectady does not have the same continuum of long-term care that Northeast Health has. Why not have all these providers in the region have some type of memorandum?
Courtney, it's a good question. And it turns out the history, or the economic history of integrated delivery systems, if you do a post-mortem on them, there was a pendulum that swung during the 90s toward integrated healthcare systems, kind of swung away, and is very definitely coming back now strong. And if you do the post-mortem, integrated healthcare systems that basically reflected referral patterns were very successful. And those that decided to be, you're the Cleveland Clinic in Cleveland and you decide to open up in Florida, did not have the same success. And a very good example, and this has come up, we've had discussions about this. If you look at Schenectady, because I did part of my residency over there, it's fascinating how little, and on Berger, we looked at these, that was one of the things we looked at, were referral patterns. Where were patients coming from and going to? Schenectady, although I don't mean to say this exclusively, but it's we don't share. There aren't patients trooping over from Troy to go to Ellis, and Schenectady patients aren't coming to Troy. There's a little bit between Albany and Schenectady, but it's not, Schenectady is self-contained. Whereas if you look at the numbers between Troy and Albany, that's a whole different there's plenty of referrals that go on between those two, although, to Jim's point, I had you were mentioning looking at the Samaritan and Albany Memorials as one. It is fascinating to look at this referral. We will have, actually just recently had a patient in the ER at Samaritan Hospital who had a 3-hour wait at least ahead of them for a bed. And we told them we could move them to Albany Memorial Hospital and we would have them on the floor and in a bed in 20 minutes. And that person turned it down because that's too far away. And it's interesting how segmented in people's minds these markets are. But to get back to your point, I think the reason why an integrated system works very well when you look at Seton and Northeast Health and St. Peter's is we have an 80% medical staff overlap between Albany Memorial and St. Peter's Hospital. Those two can operate just almost as one very, very smoothly. And obviously we have a tremendous overlap between St. Mary's, Seton, and Samaritan and Troy. Almost all medical staff go between the two. So we think that matches up well and will work both in terms of the realities of this marketplace and what's been successful for integrated systems. It's an interesting question about Schenectady, but I think the reason it hasn't gravitated that way is that's not what the referral patterns are. As Jim said, the patients aren't voting with their feet.
I suppose the first thing to say is I'm not so sure down the road the model isn't going to broaden and be more inclusive of all the organizations. I think that's the Berger echoes that we may be living with for the next couple of generations. It'd be interesting to come back and see what this looks like in 20 years. Might be just one system. Although I do think the referral patterns in the local communities come into play. I also think the danger of getting too big is you lose sight of what you're trying to do. Large systems, I think the major benefits they bring to the table are access to capital and negotiating power with the third-party payers. They also say, oh, we're going to get economies of scale, we're going to make you more efficient. I've yet to see really that happen. I think you got to remain a little bit nimble in operating and being responsive. But I think alignment down the road in terms of the continuum care and working with it, I think alignment can happen. I think the efficiencies can happen with that without bondage. That's my new motto. I'm into alignment, not bondage.
And Courtney, I have to be honest here, Sunnyview Rehabilitation Hospital is part of Northeast Health and is sitting right there connected as well, and we have a PACE program over there that's been very successful too.
And the alignment works.
Yeah.
Great. Okay, we're going to take some questions from the audience, so we do have a microphone. So.
Joe Moffitt from Catholic Charities. How are you? I was curious. I did, in your discussion of the new model and medical home concept, and I look around and I see you have very large facilities with tremendous capital base, and a lot of you are doing new construction with a lot of debt service that are going to be accommodated that. What makes you think that in a new model with a medical home that, in fact, the institutions will be the ones controlling the healthcare and the patients and not the private practicing physician that's out there, which, as you know, we have a bone and joint center, we have ambulatory surgery centers that have been taking business out of the institutions for a long time. They're basically uncontrolled at this point. So when CDPHP, say, launches a medical home and wants to have payment associated with that, what makes you think that they will say, well, we'll pay for the more expensive coordination through the institutional model versus we'll pay the private practicing physician groups, primary care, community care, all that, to do that. They'll do the coordination, and you'll just have to sit back and see what kind of business you get. I'd be interested in your comments, because you really didn't talk much about the private practice.
Well, okay, I'll respond to that. Being a physician, I mean, at the end of the day, I've said it often. Actually, in my office, Craig Duncan was my predecessor, and there was a little framed statement on the back of his door. So when the door closed in a meeting, he looked right at this, and the little framed statement said, "It's the docs, stupid." At the end of the day, it is the docs that drive the bus. And in fact, it's that physician-patient relationship that we're trying to drive. I mean, that's what you really want. And I absolutely agree. I mean, the docs are going to determine a lot of the success of all this. However, you raised what I think is really the core question here on the medical home, on the specific question you asked me, and what I'm going to be spending tomorrow morning engaged with the CDPHB board is, what are the payers? How do the payers feel about this? Now, there are those, if you read in the medical literature now, there have been articles about it and so forth, who say that ultimately, if we are to be successful in getting our hands around costs, an integrated healthcare system is a first step. But until the payers are integrated into that model in some way, we aren't really going to get there. And I would answer you by saying, I don't know, and that's why I'm going to be up there, because I think John Bennett, CDPHP, Dave Oliver, MVP, I think a lot, we're going to create this, and then that relationship is going to be absolutely crucial. Now, the thing we're going to be talking about, and I was talking a little bit about it before, are some models, for instance, and I'll throw one out called ACOs, Accountable Care Organizations, where the payers really want to do what Medicare wants to do. I'll use an example. What Medicare really wants to do is say to, you have a hip replacement done and you need to then exit the hospital and have rehab. Now, if you go to home care, and one of our home care physical therapists take care of you, it's going to cost a certain amount. If you go to our inpatient rehab hospital, Sunnyview, it's going to cost a very different amount. And if you go to one of our subacute rehab units in one of our nursing homes, it's going to cost a different amount. And Medicare will pay that different amount depending upon the site. What Medicare really wants to do, and ultimately the commercial payers, is to say, look, we're not going to tell you the right way to take care of this from a cost standpoint or clinical standpoint. We're going to pay this much for this diagnosis. You, integrated system, decide where that patient ought to be, what's the right place for them, both from a cost standpoint, cost efficiency standpoint, and a clinical standpoint. That's where it's really going, and these accountable care models, which is what we'll be discussing, look at the same thing. They'll look at a particular diagnosis or a particular specialty and say, physicians and doctors, we don't want to start, you get professional, you get technical component and so forth. This is how much money the community's got to pay for this particular diagnosis or for this particular specialty, and that's what we're paying. You guys figure out how it's going to get divvied up and so forth. So to your point, the question is, so how do we align? How do we align with the physicians? One answer is, it's years and years of a pissing match. The other answer is, well, you start employing. More and more physicians become employed physicians, which actually many residents coming out of residency actually are preferring right now. I don't know which of those models pans out. I think the question is absolutely central to where this thing finally, it's easy to put the integrated system together, quote unquote easy. I think the question is to how the payers want to participate in that and the physicians participate in it isn't just an interesting question, but it's the one on the table now in terms of Medicare and in terms of these accountable care organizations that the payers want to start pushing. It's a bit of a punt, but you hit the right, I agree with you.
I don't think we're assuming the institutions will drive the entire train either. I think we look at things like bone and joint center or ambulatory surgery centers and look at the changing rates on the Medicare side and say, over the next 3 to 5 years, their rate's going to get cut. And so it's going to cut back on this proliferation of freestanding centers and push everything back into the institution. But as to Jim's point, it's all about the doctors, always has been. And I think when you really talk about delivering care in the community, always will be. I don't have a huge number of doctors trying to beat their way into the Schenectady community to take care of the poor. They just don't want to do it. So, how do you take care of them? It requires the hospital to step in and start to employ them. So we're taking on this role, not necessarily because we think that's our mission. That's not where our mission in life started. It's where our mission in life is starting to turn towards. If I were to talk about two of the greatest medical needs in our community, I'd be talking dermatology and endocrinology, neither one of which need a hospital to function. But I need to help support bringing them in. And then you have, services like, radiation oncology, neurology, neurosciences, and neurosurgery, even general surgery, where you probably need more physicians because it's taken too long for the patients to get in. But the physicians, it's kind of like this, how many hospitals do you need in Troy? 1.5. Well, they don't need another full physician in the practice that can't support it, with the current income streams. But they could sure use a half. Well, where do they have to get the other half? I think we're going to continue to see the hospitals go into more and more employment of physicians. I'm not an advocate of the employment model, but I think we're going to end up in a hybrid. And like Jim said, I'm not sure exactly what that hybrid is going to look like.
Joe, so what it really does is punt the ball back into the court of the physicians and the payers, this kind of consolidation, because it says to the docs, what kind of relationship do you want? Do you want to stay independent, be in a large group, like big orthopedists or whatever the case might be, and develop a relationship, or are you going to force the system into basically having to hire their own. And so I think it's the same way with the payers. It basically puts the ball back into their court to some degree.
But aren't the two largest payers basically physician-owned?
Yeah.
And they want to keep control of that? Okay, thank you.
Just so this is sort of a follow-up to that point. When you mentioned the accountable care organizations, it seems to me that that really is about the patient, not just the doctor, because it's about the outcome. Ultimately, it's a reimbursement model that looks at the outcome. So my question is, there was a lot of talk after the first Berger Commission about the need for a second Berger Commission, that commission would focus on reimbursement to change the system. With the advent of these accountable care organizations, if you're able to do that in this area, I don't know if it's been done anywhere else in the state, will that therefore get rid of the need for a second Berger Commission?
I don't think the Department of Health wants to do another Berger. I think they got kind of, even though it was a highly effective mechanism, it was painful. I think the better approach personally is to find some organizations that are committed to making a change, to being innovative, and fund them. And when they're successful, then let them that model roll out to others. I don't see another broad-based Berger 2 coming through. Hopefully they'll pick some models where they have true champions and that are really committed to making a difference in changing the model of care, and they'll fund those and then hold those models out for others.
Yeah, Courtney, I mean, I would hope that we allow the evolution to be established here. To my answer about punting the ball back into CDPHP's court or the physician's court on this by forming these consolidated healthcare systems, there will be a process of evolution. And we first got to put these systems together. Then we've got to address exactly, to Joe's point, well, okay, so what does that imply about this relationship with the physicians or this relationship with the payers? I think if you had a Berger 2 right now, it couldn't do the reimbursement changes because we're only starting to coalesce this now. This accountable care organization model, for instance, you couldn't do without really an integrated, at least some sort of an integrated system. So we're only getting to the point where you can test some of these out. But I will say, now this has been said to me by CEOs for payers outside this area. They said the capital region is the area that ought to be trying these things because we have a very interesting laboratory here. We don't have a lot of outflow. I mean, I used to send, I occasionally had a patient who wanted to go to Dana-Farber in Boston or Memorial Sloan Kettering down in New York, but by and large, we really take care of our patients in this area. And now that we've got a couple of large payers, and if we get a couple of large healthcare systems, we kind of have the situation where you could really start modeling some things. And there's a couple of people I'm thinking of, their organizations, their insurance companies aren't even in this area, and they think this is the area where we are best set up in the state to actually try some of these models. But I don't know that the state should try to do that right now through Berger 2 because I don't think we have the pieces in place to do it.
Another question from the audience.
My name's Dr. Arnold Ritterban. I'm a retired. My name's Dr. Arnold Ritterban. I'm a retired internist, and I'm one of the founders and co-medical director of Schenectady Free Clinic. I'd like to ask you a question that you may think is irrelevant or perhaps not want to answer. Do you think there's any real way that we can control health care costs in the United States without a single payer system?
I was on a panel not too long ago on the future of healthcare. It was over at the RPI did it at the Biotech Center, and that question was asked at the end of the day. It was during the campaign, so we came in, Obama were still running, and they said which of the two candidates would actually at the end of the day wind up lowering costs of healthcare in the country. And my answer was, I'll be totally honest with you, if I really sit at night and stare at the wall, having been in pretty much all the sides of healthcare, I don't think any of the programs out there right now will significantly impact healthcare costs. Obama's comment, I heard, both of them, we're talking about healthcare information technology, and I looked at this, a few hundred people in the room, and I knew a lot of them were in healthcare. I said, how many people currently involved in healthcare have seen a decrease in cost as a result of IT investments? And there's dead silence, no hands up. Now, I'm setting up a straw man because long term there probably will be and so forth and so on. In answer to your question, if you ask me how there's a deal in this country in healthcare, and I learned it when I first came into healthcare, and the deal is between our society and basically our government, and that is, if you need it, you'll get it. One way or another, you're going to get treated. If you show up at an ER, the Emtala law says we got to treat you, and it isn't one of these things that people think that, if I had a patient rolling into the ER who had pneumonia, well, they're on Medicaid, they get this treatment. I treated pneumonia one way. In fact, I used the example when I was in residency. I can remember I had a patient who needed a procedure, and I said to the nurse, could you check what insurance they have? And she went down the hall, and she yelled back down the hall, and she said, they've got the gold card, they're all set. You know what insurance they had? They had Medicaid. When we were Medicaid, if someone was on Medicaid, we didn't have to check anything, at least at that point, and so forth. And my point is, I don't think you can really change the cost curve as long as we basically have this promise to our society that we'll do everything. Because we can redesign business models and so forth, and I do think we can bend the cost curve a little bit. But until we're actually ready to start saying, and this experiment got run in the 90s. The HMOs in the 90s, I was in practice, really started to close the door. There was the gatekeeper concept. If I ordered an MRI on a patient young lady with weakness in her right leg, wanted an MRI to see if she had a disc gone in the bottom of her spine, didn't get approved. They said, you're going to treat her the same way conservatively 3 weeks anyway, aren't you, Dr. Reed? So the HMOs really clamped down in the 90s, and what did the cost curve do? It actually started leveling out in the 90s. And then what happened to the HMOs? They got taken to the cleaners. All of us were all, what do you mean you're going to deny that MRI? What do you mean I can't have this? What do you mean I can't have that? So what did the HMOs do? They opened the floodgates back up. The gatekeeper, all that stuff disappeared. And what did the cost curve do? It went right up. So we've already run the experiment as to what you need to do to flatten that cost curve. So and nobody wants to go there. I don't know any politician who wants to go there again and question the social contract. And the social contract is, we will take care of you in this country. And someday, somebody's going to step up and say, if you're really serious about cost, we're going to have to answer that differently. We can't always take care of you and do everything. I went to speak, and I was invited a few years ago to speak in South Africa at a couple of conferences, and in between I got invited to go to Berger Hospital, which is a big hospital in Soweto, and a lot of all sorts of problems. And while I'm there, he said, oh my goodness, would you like to meet Dr. Colin Eisenstein? And I said, who's Colin Eisenstein? Well, Colin Eisenstein was the worldwide director of healthcare for Anglo-America, lines all over the world. So he knows every healthcare system in the country. And I'm sitting at a table like this size, and he's right next to me. And I've known him for about 60 seconds. And he turns to me, and he goes like this, he says, Dr. Reed, do you know what's wrong with healthcare in the United States? And I said, no, Dr. Eisenstein. What's wrong with healthcare? He said, you are making promises you'll never be able to keep. And that's exactly what he was saying. We basically have a social contract that says we'll do everything, and we don't have the resources to do that if, in fact, we really want to flatten that cost curve. So my answer, and I don't want to go on for too long, but we keep looking at the cost, and we look at the supply side of this, and the issue is over on the demand side where we have